Hi, I'm Dr. Charles, and I'm with Dr. Gietzen again, and we're here to share another case with you guys.
Yeah, welcome. We're excited. So, what is the clinical history on this case, River?
So the patient is a 64-year-old female with a history of diabetes and hypertension who presented with headache and double vision and was found to have increased IgG levels, acute kidney injury, and cholestatic liver disease. The creatinine is 2.5, and urinalysis showed 2+ protein and no blood.
Okay. And so, let's get straight to it. What do we have on light microscopy?
So by light microscopy, we could see severe tubulointerstitial fibrosis that essentially involved 100% of the cortical sample.
Oh, wow. Yeah, there's a lot of scarring in this cortex.
The areas of interstitial fibrosis show a dense reticular pattern that we could see here on a silver stain. And then within areas of fibrosis, there is a severe plasma cell-rich inflammatory infiltrate admixed with few lymphocytes and eosinophils.
That's a lot of inflammation. So, what about the glomeruli?
So as we could see here, glomeruli were normal in size and cellularity without mesangial matrix expansion, mesangial hypercellularity, segmental sclerosis, or any other atypical features.
Okay, so most of the findings are in the interstitium.
Yeah.
Okay. And do we have immunofluorescence?
Yes. So the glomeruli show diffuse mesangial granular staining for IgA, as we could see here. So IgG staining as seen here is negative within glomeruli. Here's a glomerulus circled that's negative. However, within the interstitium, IgG highlights numerous inflammatory cells, and these same cells stained equally positive with kappa and lambda. And then moving on to kappa, there was trace kappa staining within glomeruli and 2+ granular mesangial staining within glomeruli for lambda.
So to summarize so far, we have a diffusely scarred cortex by light with a dense reticular pattern and sheets of plasma cells that are polytypic by immunofluorescence. And then we also have this IgA that was staining by immunofluorescence. So did you order any other stains to work up the plasma cells?
Yes, IgG and IgG4 immunoperoxidase stains were performed, which showed frequent IgG and IgG4 positive cells. So here we could see the IgG stain, which highlights numerous plasma cells that stain brown. And if we look at the IgG4 staining, we could see sheets of plasma cells that are staining brown, and it highlights that there's greater than 10 plasma cells per high power field within the renal cortex.
Okay, so that would be positive then for the stain.
Yeah.
So what does the EM show?
So overall, electron microscopy was showing uniform glomerular basement membranes. There was no immune complex type electron dense deposits within the capillary walls. The epithelial foot processes were mildly effaced. The mesangium showed rare immune complex type electron dense deposits, and the tubular basement membranes were without deposits.
Okay, so overall, what was your final diagnosis?
So the biopsy findings are consistent with a chronic tubulointerstitial nephritis consistent with IgG4 related disease. Renal involvement in IgG4 related disease may present as a discrete mass or a diffuse sclerosing tubulointerstitial disease. Since the fibrosing process may be localized and abruptly transition into normal cortex, the degree of fibrosis in the biopsy may not be representative of the overall extent of renal fibrosis. Therefore, correlation with radiographic images is recommended. Patients often have laboratory abnormalities that can support the diagnosis, such as eosinophilia, low complement, and hypergammaglobulinemia with elevation of serum IgG4 levels, which was present in this case. Additionally, in this case, glomeruli showed evidence of a concurrent IgA nephropathy with no active glomerular lesions seen by light microscopy.
So let's ask the audience now if they think these two diseases in the patient are separate entities or if they are related. So thank you for joining us, and we'll see you next time.